delighted to have her. She's a U.S. Board-Certified Pediatrician and Public Health Physician and founder and Medical Director of Ingress Health Partners. Here, she's working on expanding integrated comprehensive primary health care, employing a continuity of care model, incorporating anticipatory guidance and behavioral change at community level. And she does this work integrating this with technology and expanded partnerships to optimize maternal, newborn, and child health outcomes. You can see how very suited she is for today's session. At Ingress Health Partners, Dr. Doherty leads a team of dedicated professionals who are engaging high-density communities around maternal and newborn care, working with local traditional birth attendants and maternity homes to improve referral patterns and establish safe pregnancy and newborn care practices. Dr. Doherty and a team established the Simpson Street Newborn Outreach Clinic in Lagos mainland, a novel initiative which provides early newborn care through outreach services within 48 hours of delivery, educating mothers and their families on safe newborn practices. Practiced using the Century model, the Ingress Health Partners team has provided early newborn services to over 1,000 babies and their mothers. The team also provides focused visits for women, addressing the preventable contributors to maternal mortality, including screening for breast and cervical cancer and other non-communicable diseases. Dr. Doherty is also the founder of African Children's Hospital Foundation, which was established with the aim of significantly expanding access for children across Africa to quality specialty care at designated dedicated pediatric centers. She received pediatric training at the Lagos University Teaching Hospital and the Children's Hospital of Pittsburgh, where she was an award-winning pediatric resident and clinician. As pioneer pediatrician in ICAP Columbia University, she led teams that established over 100 maternal and newborn care clinics for mothers living with HIV in several states in Nigeria, creating curricula for training health providers and tools for supervision. Until 2019, she was country director for Africa and Nigeria, where she provided thoughtful leadership around enhancing the capacity of women and their families to improving health and livelihoods through behavioral change, education, and enhanced access to resources and technology. At Africa, she also worked extensively with youth programs, integrating sports and life skills. Her 29-year professional career has spanned clinical and academic pediatrics, health and hospital system strengthening, community development, establishing livelihoods, and the promotion of life skills in women and young people. She's a fellow and a moderator of the Africa Leadership Initiative of West Africa and the Aspen Global Leadership Network. She's also a moderator of the Aspen Health Innovators Fellowship and the Kashim Ibrahim Fellowship Program in Nigeria, a fellowship for young Nigerians committed to public service. She holds a master's in public health, maternal and child health from Harvard University School of Public Health. Please, I would like us to give a round of applause to welcome Dr. Orode to this session. If you don't clap, she's not. Mike would please make sure that you're clapping so that she can feel welcome. Thank you, Dr. Orode. Over to you. Thank you for joining.
Thank you very much.
Please make sure you are clapping. Thank you.
Thank you, Elizabeth, and thank you everyone for coming. We do not take it for granted that when we invite you to come, that you will come. So thank you very much. Whoever is on the slides, let's just go straight into the first presentation slide. So we're going to be talking about influences of utilization of essential antenatal care. And I think that what we want to start off by doing today really is define what we will be learning during this session. So we'll define essential antenatal care and explain why it's critical, and then speak to the factors that influence utilization of antenatal care and how we can improve uptake of essential antenatal care. And then really importantly, for many of you on the call, we'd like to speak to the case for deepening community engagement to increase utilization of essential antenatal care. And obviously, because we are partnering with MDOC, and MDOC has sort of revolutionized how it is that we think of technology in healthcare, we're also going to be talking about how technology is improving the utilization of antenatal care services in Nigeria and indeed in other parts of the world. Next slide, please. So essential antenatal care is really a form of preventive healthcare. What it does, though, is it focuses on the pregnant woman and her unborn child. So everything you think about when you think about primary care prevention is the same thing. But we're saying now the center is the pregnant woman. And what it does is in the same way as primary healthcare does for every other person. For the pregnant woman, it involves regular visits, screening, advice, treatment as is necessary, and support for all of the various health issues that women get when they go to a skilled health personnel. The emphasis is on skilled health personnel. Sometimes we do essential antenatal care in bursts of outreach, but it's not the same thing as when you go to the personnel where they can give you all of the services that they are capable of giving. WHO has come down now and said you have to have had 4 antenatal visits appropriately spaced in order for you to have been said to have received antenatal care, essential antenatal care. Next slide, please. So what I'm going to do in order for us not to sometimes what we find is that women make up their minds, and indeed this is our desire, that women should choose where it is that they will receive their services, because a woman's choice matters. As a result of this, though, you may find that the quality and content of antenatal care may vary. And the idea is that women make a choice. What is therefore accepted and recommended by WHO is that we should have a person-centered approach. So the woman should be at the center of everything that we're doing. We should respect her rights, her values, and her choices, and ensure that wherever it is she goes, to the extent possible, we should provide her with the amount of healthcare and the extent of healthcare that can be provided at that level of care, with all the evidence-based information and options. So sometimes, like I said, we will provide an outreach service to a place where that specific service is not being provided. But what is optimal is that to the best possible extent, women should receive good quality antenatal care that is comprehensive. And of course, in our project Aisha, which is our 3-year MSD for mothers funded project, that's aiming to drive down preventable maternal deaths by 20% in Kaduna and in Lagos. We emphasize the delivery of women-centered care that leverages women's voices to achieve 0 preventable deaths. Everything we're talking about today, just remember what Dr. Monsemi said, everything is to drive down these deaths to 0. If a death is preventable, we don't want it happening in any of our facilities. So what are the benefits of, next slide, what are the benefits of utilizing essential antenatal care? One of them, and there are many of them, sorry, is this our next slide? Okay, sorry. Which one is the next slide? Is it 27? Right. So why does it matter? Dr. Mosemi explained earlier that we have no business having these high numbers of deaths in a country that is so well endowed. But Nigeria continues to contribute to a full quarter of the total number of deaths of women in the world. We don't have a quarter of the population of the women of the world. We should not be contributing to this number of maternal deaths. And all of these, almost all of these deaths are preventable, right? So if you have preeclampsia, postpartum hemorrhage, and prolonged obstructed labor in any woman, we are indicted. We should not be having any of these. If women are able to access essential antenatal services, we should be able to anticipate. This word is important. Anticipate them and guide them into the necessary type of care for them to deliver where they can get comprehensive emergency obstetric and newborn care services. So this is an important part of the work we do. This is why this matters. They are preventable, and therefore we should not be recording these deaths. We do what we're supposed to do every time, and the women are engaged around ensuring that they're getting the right kind of care. We'll drive these deaths down very quickly. So why is it important? Why? What are the benefits? Well, one of the benefits is definitely that if we see a woman on time and we identify, like the woman that gave her feedback in the Navi Health feedback earlier, that if we identify this high blood pressure, we can start to treat it. So we can treat chronic conditions. We can prevent preeclampsia, eclampsia, anemia, infections, and premature birth, just because we can see, as it were, the steps going in that direction, can anticipate that this woman who is doing this now, at 20 weeks, at 35 weeks, she may be doing even more, and we can intervene. In the same way, We can manage diabetes, manage HIV. We can identify women. You know, if a woman's PCV is low at the start of pregnancy, she's only going to get hemodilution. It's going to drop through pregnancy. We can ensure that she's getting the iron infusions that she needs, or the iron and folate oral supplements. We can identify that she lives in an area where she's prone to malaria and provide her insecticide-treated nets. Get everybody to get a tetanus shot. These are the reasons why we do what we do. We must, and we know we've done this for 30 years, 40 years, but we're not capturing all of those women consistently. And this is why we're having this conversation today. You can also help women prepare. You know, it's one thing to have a baby and have a baby safely. It's another thing for that baby to thrive and to go through the fifth year of life. We're still recording stillbirths, unfortunately, but preterm deliveries and the newborn and infant deaths. So all of these antenatal interventions help us also to prepare for parenthood through education counseling and then birth planning, so mothers are able to appropriately space their deliveries and make sure that they don't have the next baby too closely to the first. Women who get antenatal care are more likely to get postnatal care. And it's in postnatal care and postnatal period that we really are able to identify women who have mental health issues, and we can identify and get them into treatment very early, especially those ones who have postpartum depression and or postpartum psychosis. Next slide, please. So what did we find? One of the things that we found was that a lot of the women are actually influenced by the things that are everyday common to them. So we did this formative study in Ifako, Ijaya, and Inekwe, which are the two of our three local government areas, the ones in Lagos, where we just identified groups with men and women and asked the questions around what influences people's accessing antenatal care. And cost of care was an issue, but it wasn't actually the greatest reason why. Cost of care has always been the thing that many of us have had in our minds as the reason why people don't access care. Well, people pay money wherever they go, but family influence and the influencers around them, so the men in their lives, the women in their lives, whether they're sisters or mothers or grandmothers or in-laws or best friends, those people really influence where women go and have their babies. We found this even in talking with our women. We prepared a few slides and videos, and some of these you will see them as they come out. Women are speaking to the fact that their friends are influencing them a whole lot. So we need to be looking to influencing the friends and the family, not only the women, but also their friends and their family. There's a good number of women who are worried about medical interventions. They're worried that they'll have a cesarean section. Some of that is because of the myths and the cultural factors and the concerns around instrumentation around delivery. Those are myths that we need to disabuse. Their belief systems tie very much into this. The attitude of the care providers is a significant part of this, and we know we're working on this. We need to do more work. Of course, when women are young, they have a greater tendency, so teenage pregnancies, greater tendency to be influenced both by their families, but also by myths and by fears, and those things all tie in. So these are the things that influence whether or not women are accessing orthodox antenatal care, and there are things that we can easily address. The other things, next slide please, that we found from Project Aisha are that among the women that we spoke with, a good 70% of them did not have awareness about healthy pregnancy and potential danger signs. That is dangerous in and of itself. If a woman does not recognize that this is a bad thing that is happening to her, she's not likely to go into the hospital. She's not likely to report back to the primary health center or to the health center if she sees it happening. And those are the things that increase maternal deaths. And then 30% of these women who do not know this even fail to make regular visits to skilled healthcare professionals. And so if we put all of these together, that's why we still have this gap. So there are people who don't know the red flags, but even then when they see a red flag, they don't know that it means that they should go, or they don't even ever go regularly. So there are gaps in their understanding and gaps in their accessing care. And that's why we're here. Project Aisha is here to close those gaps. The delay in the decision to take a delivery, and then at the level of the health facility, we want to close the gaps also in the delay to the right kind of decision. So what are the strategies we are therefore implementing? Next slide, please. One of these strategies is advocacy. We're talking to women at the level of healthcare at the level of the communities. We're speaking with them, raising awareness, speaking about maternal health rights, and bringing communities together to ensure that that they are asking the right questions and driving women into care. We're obviously working with the health force as well and encouraging positive attitude and compassionate care provision by healthcare providers, because this creates a supportive environment that causes women to continue to seek services without fear or stigma. You all know that if women know, the more they know, the more likely they are to interrogate and to engage. So empowering women with comprehensive health information enhances their decision making and closes that first delay that we talked about. Engaging men. Now, we've always engaged men. Yeah? Many of us have worked in the HIV space, we've worked in adolescent healthcare, we've worked in different areas where we've always talked about engaging men. This is not just engaging men for the sake of it or because they are going to pay, but because we now know that they have a significant influence outside of costs. They have a significant influence on where the woman delivers. It's sometimes it's a bit of a patriarchal attitude. If I say she's delivering there, she's delivering there. Well, sometimes that saves the woman's life, and the woman comes back and says, if only I had listened to my husband earlier. We don't want to encourage a situation where women's choices are not being taken as sort of first. But we want to encourage and ensure that both men and women are making the right decisions for each woman at every turn of their pregnancy. There's some things we can't do very much about, even though we're advocating very strongly. We haven't, as a project, attempted to directly address the improved transportation system that allows women to go from the point of the decision to the point of getting to the hospital. But we're happy to share with you, and I'm sure many of you know, that some of our health facilities have actually taken that responsibility as part of their quality improvement engagement. And we're really excited about that because the numbers are showing. We're seeing a doubling of the number of women who are completing their referrals. We're very proud of them and want to encourage them to continue to. We're engaging with government all the time. Dr. Mosemi is here. He's representing the state government, but we're also talking with all the other stakeholders at the level of the Primary Healthcare Board, at the level of the Ministry of Health, at the level of all the agencies to ensure that our women's health, and Lashma has actually begun to look into this, and nurse-led facilities are being empaneled as we speak because they are providing maternity services. So we're making progress. It's been slow, but it's certainly improving now. And hopefully this will improve affordability of care. Next slide, please. So what are the dynamics? The next 3 slides, we're going to talk about things that are all interrelated. So I'm going to bring them together pretty quickly. There are various things we refer to as the dynamics that inform the choice of essential antenatal care. And there are 5 broad categories. So health system, cultural, social factors, demographic factors, and then previous experiences with other maternal health care providers. The idea is that all of these things are interrelated. So a woman who, for example, comes from a family where they have a certain belief, that's tied into the demographics where she lives, the practices of their families and their women. It may be tied into their experience in the past with orthodox healthcare providers. It may tie into the fact that when they get there, they are unable to really communicate at the level of the healthcare facility. It may be that in a previous experience, they did not have the confidentiality or the privacy that they required. Next slide, please. And so these dynamics, these interrelated factors come together to determine whether women access essential antenatal care or not. Social factors and demographics have spoken to a bit. Remember that we said that women are greatly influenced not only by their family members, but also by their peers. And increasingly, communities are being made up not only in the geographic space, but in the virtual space. So a lot of women now are not only influenced around how they seek antenatal care by what happens in the physical, but also their social media interactions. And that's an area where we too are becoming involved in ensuring that we're getting to all of those places, and all of those individuals and communities that influence the choice of essential antenatal care. Those are the places where we are also getting into to ensure that our voices continue to be heard. Obviously, we talked about this. When women are younger, when they are less educated, when they are poorer, or if they are unmarried, or they are rural dwellers, and indeed, if they are an urban dweller who is one generation removed from having lived in their village before, they will bring all of their cultural practices with them. And if their comfort is with, for example, going to a traditional birth attendant, it doesn't matter if the primary health center is next door, they will go to the place where they are comfortable going to. And these are the things that we must be thinking about when we are interacting with our patients and their families, to say, we know you're used to doing this in a certain way. However, we have an option for you to kindly explore, and we will see to it that things are easier for you and you don't end up with complications that we could have prevented from long ago. How do we, therefore, if you go to the next slide and the next one, so this is basically previous experience with other maternal health care providers. I spoke to this, and what it is that people trust. If I trust the TBA, then and there's never been a reason for the TBA, for example, to make me feel that that trust was misplaced, then I'm going to go there. Just earlier on, we looked at one of the Navi Health pieces of feedback, and they said you get there on time and then you wait for a long time. Those things affect a lot of people. One of the nurse-led facilities, in fact, one of the consistent thing, all of the people that came to receive antenatal care one day when I visited, was that they said they are in and out in a very short time. Nobody wastes their time. Many of these people are traders. And if they want to be in and out in a very short time, then we have to think. This is when we say we're respecting the choices, the values, and the rights of women. This is what we're talking about. Next slide, please. So how can we broadly improve the utilization of essential antenatal care? Everybody, from the level of the health provider to the level of the policy decision maker, the Ministry of Health, the people who make funds available, all of these people are involved in this, right? So affordability, financial incentives and subsidies, ensuring that health insurance covers pregnancy. In some private health insurance, if you're pregnant within the first year of your signing up, your pregnancy will not be covered. So Lashma has stepped in now and said everybody who is in the state should be covered, and everybody will get pregnancy cover. And so that is one opportunity to make sure that women are covered. So that's a financial incentive, that's a subsidy. Health education and behavior change communication is part of what we're doing on a daily basis. We're looking to design strategies that are tailored to the needs and preferences of our women in their context. And this is why leveraging the voices of women is important. This is why, for example, reading the Navi Health feedback is important for us, because as we get it, we're coming back and making sure that the practices are changing as the women are indicating their desires. The prolonged wait time is something that we believe that people are going to start looking at and making a change around. Empowering women and their families to participate in the planning. One of the ways we've done that is sitting down with the World Health committees and getting them to go and sit down at the level of the communities, bringing them together in small groups and getting them to have conversations. Because that way, women are telling us also, in addition to providing Navi Health feedback, they're telling us, the ones who maybe they cannot speak English or they cannot read and write, they're telling us what they want to do. Getting men involved, engaging at the level of butchery associations, NURTW, who have been very helpful, by the way, as well as all the communities of men, to really get them to think about how do we ensure that this pregnant woman who just walked past us as we're having this conversation, we don't one day hear she died having the baby. And then, of course, their involvement, community gatekeepers, opinion leaders, in their involvement on maternal and newborn care and survival strategies. Just again, elevating the conversation, taking it to the highest levels of decision making, and ensuring that they are seeing not just numbers, but families and numbers. And this is where community NPDSR is now becoming the way to, so we bring back, have a community dialogue, have a verbal autopsy, bring back that conversation at the level of the community so that they can see where things went wrong, and hopefully we can prevent that from happening next. Next slide, please. So here, I think we're going to talk about now some of the reviews from Navi Health. We've seen a couple of them. Go to the next slide. And again, we see good news and bad news. They loved the effectiveness, and they told us that I was invited by a friend that told me this hospital is a very good place to come to. I had to come all the way from Oshodi. My friend told me it's a very good place. This is my first time coming here. It was someone that directed me. Can you see that in both of these, we're talking about the influencers. A friend told them, I was directed by somebody. I was invited by a friend. These two people were influenced by somebody. They'd never been to this place before. Each of them had not been. It's a person whom we may never have considered was important for us to get to know, right? So positive reviews can come as a result of people that were referred. On the other hand, women will also give their negative feedback, right? Again, this was about silliness, delaying too much at antenatal visits. All the other families left because of this reason. I wouldn't have been here if not because I had registered earlier. So when we don't see a 3 or 4 star mark, we're not very happy. But you know, we're taking a step back. One of the things that's happening in antenatal care now is that next slide please, is that we are leveraging technology to enhance utilization of essential antenatal care. And there are very many ways in which we're doing that. One of those is the 2 slides we just saw, this slide we just saw with all the 4 pieces of feedback from Navi Health. We're able to provide information and education to pregnant women and their influencers, either interacting or through SMS, WhatsApp, various mobile applications, Telegram. We're able to send information and get women to look through and identify if they fall into any category. If any of this is happening to you, you should report to your nearest primary health center. Then they can interact with us. We're also able to get women to adopt healthy behaviors and practices through social media and mass media communication. MDoc does this very well. Many of you have seen the interactions that they have, both in the physical, like in the marketplace, as well as the messages that they send out. So adopting healthy behavior, getting people to do exercises, getting people to eat healthy, getting people to adopt certain nutrition changes and making changes to their diets. This is another way that we can use technology to enhance utilization of essential antenatal care. And it's working for us. If women understand that they're able to do this without their having to come to the health facility, when they come to the health facility, then we can go even longer with them. Improving availability, accessibility, affordability, and quality of antenatal care services through platforms including telemedicine, electronic health records, and decision support systems. That makes a huge difference. Sometimes you have somebody that's not as experienced as the next person, but because they have a decision support system, they can make all the right decisions for everybody, and you streamline and make sure that everybody is getting the same quality of care because you're using decision support systems. You're not just saying, oh, from my experience, this is what we do. No, beyond your experience, this is what we should do as providing good quality healthcare. Next slide, please. One of the other ways that we're leveraging is we're providing remote monitoring and virtual care. So there are some women who they cannot come as frequently as you would like them to, but they have a blood pressure machine at home, and you can get them to learn to take their blood pressure appropriately and only come in when it becomes necessary or at designated times when you must lay eyes on them. We're also able to use technology to engage women and empower them and their influencers to participate in the planning, delivery, and monitoring of antenatal services. So whenever it is that we have a question, we can push that question out, and through virtual means receive feedback in order to change whatever it is that we are doing. Obviously, we use technology. Elizabeth was saying this when she started. She says we're using all of this information to streamline and to improve what it is we're doing. So data collection and analysis is important. We use it when we're teaching. We use it when we're providing services. We use it when we're analyzing the services that we have provided. And obviously, policy advocacy and social change is another way that we're able to use technology. So we're speaking here. Our funders are on the call. Our beneficiaries sometimes are on the call, and a lot of the time, the people with whom we're working are all on the call. So these are all the ways that we're now using technology to improve outcomes and to improve the uptake of essential antenatal care. I want to thank Team Ingress. Been very helpful with preparing these slides. My schedule has been, as many of you know, a little wild in the past 2 weeks. MSD for Mothers, thank you very much for the funding support. And a big shout out to the MDoc team. They've worked with me on the slides, worked with me on ensuring that we had our questions in early and ensuring that these slides were so nicely put together. It all looks pretty now because Elizabeth and her team had access to it. So thank you very much. And we'll take questions from you all and proceed. Thank you.
Thank you so much, Dr. Orode. That was such a robust and I'd say really remarkable. I expect the claps to start to come in the chat box now because Dr. Orode has been this has been a very resourceful, very full of rich insights and takeaways for everyone, regardless of the space in which you're practicing or the space in which you're, interfacing in the maternal health landscape. So thank you so much, Authority. That was full of insights, very rich, and we appreciate you taking the time. Thank you for also, casting a spotlight on the work that MDoc is doing in also improving this outcomes. And we appreciate it. Thank you also to the Ingress Health team for the work that was done. Thank you so much. So